Dr. Michael Jackson, he is a dentist in practice for 31 years now. He's a fellow here with the Academy. He is a graduate from Baylor College of Dentistry in my home state of Texas. He is also a doctor of integrative medicine from Capital University. He is chairman of the Jawbone Pathology Committee, editor and contributor of the IAOMT position paper on jawbone osteonecrosis, sergeant of arms, and the incoming administration vice president. Dr. Michael Jackson.
I'll give some information that for people who are just learning about these, as I was 15 years ago when I first came to the Academy, so that we'll have some basis for discussion, but it's not a technique course. I'm not going to be teaching you how to treat these things in this. We're going to be giving overviews. I came to the board of the IAOMT in 2006 and was asked what my interests were in terms of helping the Academy, and I told them that I had an interest in jawbone lesions. And so by default I became the committee chairman. And one of the things that Kim told me was that for years they'd been trying to get a position paper that had the basics that we could say represents our Academy as far as what our thoughts are. And so we've been working on that since 2006. We've had many drafts, and so when I submitted the paper at the last meeting, they said, well, why don't you do a lecture on jawbone osteonecrosis and the Academy's position. So that's what we're going to try to do here today. We're going to give some history, peer-reviewed research, and the position of the Academy. The other members of my committee that have participated in this are Drs. Richard Keller, Blanche Gruby, Stuart Nunnally, and ex officio Robert McMahon has written some stuff for us to consider and to use also in the paper. I'm going to have to stand over here to make this thing work, looks like. So again, we're going to be talking history, facts on jawbone osteonecrosis, diagnosis, treatment, related topics, a conclusion, and then we'll give an overview of the position paper. I went back when Michael Ziff, years ago when I first, I'd been probably a member 5 years and went to Michael and I said, I want to do something for the Academy. I've been sucking up enough, so what can I do to give back to the Academy? And he said, well, what are your interests? And I told him again that it was jawbone necrosis issues. And he said, well, we can't prove that it exists unless we have a library. So one of the first things I did for the Academy was I went to our local medical school library and I got as many pertinent copies of research articles that I could get, made copies of those. I kept copies and gave a copy to Michael for the Academy library. So we have a library that probably, with the old material and some of the new stuff that I haven't made available to the office yet, we probably have 100 articles or so on this topic. Let's go through some of the early contributors. Dr. Thomas Boyd was a medical doctor, and he was the first dean of the Baltimore College of Dental Surgery, and is the man credited for first using the term oral medicine. He wrote a textbook titled A Practical Treatise of Dental Medicine, and was the first English language text devoted almost exclusively to oral maxillofacial pathology as we know it today. He's also known as the father of oral and maxillofacial pathology, and in his textbook he broadly outlined the term bone necrosis, which is osteonecrosis, bone caries, which was osteomyelitis, which is infection, of course, and also described neurologic pain from damaged or inflamed nerves in the jawbone, which he called neuralgia faciae. Now that's 160 years ago, and isn't it interesting that he had that knowledge and that understanding, but we still have practitioners and people in power that say that we still don't know where trigeminal neuralgia and atypical facial pain and some of these other maladies of our patients, they have no idea where that stuff is coming from. Dr. Noel in 1868 gave a lecture And he further broke down the label of pathological jawbone as either dead or the less damaged, reduced vitality. Same concept described a different way. 1898, Dr. Barrett, in a textbook, Oral Pathology and Practice, describes noticeable defects of the human jawbone. So in the 1800s, we have doctors that were seeing and describing defects of the human jawbone. G.V. Black, father of modern dentistry, unfortunately a promoter of dental amalgam, I believe, but also in a book wrote on special dental pathology, a work on special dental pathology described hollow spaces and outlining protocols for cleaning them out and allowing for healing. He talks about finding these cavities or hollow spaces, using a curette, cleaning down to vital bleeding bone, and then closing and allowing for healing. Same premise that we use today. And then there wasn't much in the research until we get to the 1970s. Dr. Ratner describes the difficulty in seeing these jawbone lesions on radiographs and describes finger pressure and injection tests to help locate them. He wrote so proficiently or so much during the 70s that they actually called these lesions Ratner cysts. And he describes the fact that on conventional dental radiographs, these lesions are hard to find. The cortical plate is so dense that you have to lose 40% of the bone before you can see noticeable changes on a radiograph. He also talked about using digital finger pressure, thumb and index finger, to press on the jawbone to try to find areas where the patients may not be aware that they have problems. I have no idea. Pardon? I still don't hear you. Are we being taped? Yes. And so he found a technique where he's using finger pressures to find these areas where there's pain in the jawbone and correlates that to the location of these lesions that he's having trouble seeing. Also used injection techniques. If he had painful lesions, he could use a little local anesthetic in the site of the pain and determine if the pain went away that he felt like that was the site of the lesion. Dr. Robert McMahon, oral surgeon, in the 90s describes anomalies of anesthetic effectiveness and called them bridging, blocking, and divergence, also in relation to these lesions. I periodically will have difficulty with a lower block, for instance, and I feel like my technique is adequate, and I'll get anesthesia in the posterior segment and maybe anesthesia in the anterior with a space in the middle. That's what he would call bridging. If you just take a few drops of anesthetic and put it in the area where there's still pain perception, and in many cases you'll get full terminus anesthetic. There's also instances where you'll get posterior but not anterior. And again, if you go to the area where the pain is perceived and administer local in that area, and in many cases you'll get it all the way up to the front as well. That would be blocking. So he added to the knowledge. I believe he also described the diffusion patterns of the face, depending upon location of lesions where you might have pain problems. Others that have followed are Wes Shanklin. He's my surgical mentor, and he's written many articles showing the existence of jawbone osteonecrosis and also techniques for treating those things. One of the smartest guys I know. He used to teach anatomy to the medical school at Ohio State. I don't know if he still does or not. Jerry Boco is an oral pathologist that is credited with the term NICO to describe those lesions that are causing a neuralgia-type discomfort. Bob Jones, he's, by the way, Cole knows that he's now moved from West Virginia and is down at the University of Texas at Houston School, head of their pathology department. One of the more knowledgeable people about this issue, at least in the United States. Bob Jones, a friend of mine, he's a survivor of jawbone osteonecrosis and is the inventor of the Cavitat device, which is a sonography device that helps find these lesions. Bob's background was that he was a pilot flying for American Airlines probably 10 years or so ago. One day he was feeling fine. A week later he was ill and was not physically able to fly, and a month later was told that he had ALS type syndrome and that he needed to get his affairs in order because he was going downhill really quick. Fortunately, he found a dentist that was knowledgeable about these things in Colorado. He sought him out and said, "Can you help me?" And the guy says, "You're so sick, I think you're going to die on me. I don't think I want to treat you." And the story is that he said, that Bob said, "I'll sign over my house and anything else I have to you if you think you can help me." The dentist went in and did surgery, took out bad teeth, cleaned out the bone, and Bob's still here with us. He used his background as an engineer and also his son's background, Robert Jones, as a geologist in the oil fields, familiar with using sonar, bouncing the waves off of the earth to find out where the oil deposits were. And together they invented the cavitat, which is a sonar type device. It's a sonography that sends sound waves of a certain frequency through the jawbone through a transducer on the outside and a receiver on the inside, with a medium to continue the continuity of the sound waves, which is usually aloe vera. And the device measures lack of density of the jawbone and also lack of moisture.
Dr. Jackson, we have a cavitat here.
Do we? Okay, I haven't seen it over there. And so they invented a device that helps the dentist be able to try to find these lesions that are quite difficult to find. Michael Margolis is an IAOMT member here who wrote his doctoral thesis at Capital University of Integrative Medicine, evaluating the cavitat device to determine size, location. He and a few other people also participated in some of the studies that allowed the cavitat to receive FDA approval. Jacques Imbeau is a Canadian, splits his time, I believe, between Canada and New Zealand, and he also is published in Cranio, writing an article titled Introduction to Through Transmission Alveolar Ultrasonography in Dental Medicine. There are opposing views. There are those out there that do not believe that the human jawbone can have an osteonecrosis, cannot have a lack of blood flow that precipitates these lesions from being formed. Based upon my experience with our trade union, I believe that's their position as well. And in JADA in 2004, there's a article that mentions NICO by name, but suggests that the entity is controversial and questioned by several authors as well. Dr. Marks and Diane Stern have a textbook with the section devoted to terminology that's no longer in use, and in that section they deny that jawbone osteonecrosis and particularly NICOs do not exist. If anybody downloaded my lecture off of the IAOMT website, I had an error on this particular slide. And I also credited Dr. Marks with saying that people that are doing this surgery should have their license removed. He did not say that in the textbook, so if you'll please omit that. That comes from a different source. Dr. Marks also has a good textbook that I have used as a reference for my next lecture on bisphosphonate-induced osteonecrosis of the jaws that I'll present after this lecture. I went to a Hal Huggins course many years ago before I knew anything about these lesions, and I was learning Hal's protocol for using chemistries to find out if you're helping people with amalgam removals, etc. One of the doctors that was participating in that class had made arrangements with an oral surgeon down there to treat one of these lesions. And the other participants in the class were asked if they would like to go watch the surgery, and so we all said yes, and we went down and watched. While they were administering the anesthesia, they were passing around the radiographs showing the site where the surgery was going to take place. I couldn't see a darn thing on the x-ray that looked unusual. They got the patient anesthetized, made an incision, took a cotton plier and started pressing upon the exposed alveolar bone. It was in a lower right third molar area. And as they were pressing with the cotton plier, the probe disappeared the end of it, into a lesion. And they took a curette and started curetting through that opening, and eventually the size of the lesion that was down there was about as big as my thumbnail. It was about the size of a third molar that might be impacted, same size as what you'd see if you'd removed an impacted wisdom tooth. It was hollow. There was no blood flow in the area. There was some black goo, but it wasn't vital bleeding or anything like that. It took about 45 minutes to clean it out. They used a periodontal probe to probe the bone to look for areas where there was softness in the bone, and when they were convinced they had it, they irrigated it, rinsed it, and got good primary closure. That was my first experience of actually seeing one of these things. After I had seen the surgery and I went back and reviewed the x-ray, I could then see the lesion. I couldn't see it before. I think some of us have blocks as far as what we can see and what we don't see. In the position paper, I make a note that there is an article which talks about, or actually it's a textbook that talks about reviewing x-rays as a subjective art, and that if you show a radiograph to 20 different people, there'll be 20 different interpretations of what they're seeing down there. So that makes the diagnosis of these things somewhat difficult. Now, I've borrowed these radiographs from Jerry Boco without his knowledge, so I hope he doesn't object. My photography skills are very limited. Talks about a hollow area in the tuberosity. This is where they had anesthetized a patient, reflected a flap, took a round burr through the top, and the burr fell into this area right here.
Could you go back to the first radiograph? Tuberosity. So it's a hollow tuberosity in an area that did not have an extraction.
That's right. I'll talk with you about a case history that I have here in a little bit. Maybe that'll help. This is an extraction site of many years' duration. Do y'all still see the lamina dura of the bicuspid and molar? That's not normal. Many of my colleagues and some of the oral surgeons that I've sent x-rays to from 30 years in my practice would tell me that that's normal. Here's underneath a ponic where you can see a radiolucency and some calcifications down in there. Radiolucencies in between teeth. Again, more of the lamina duras and what they call a Jacob's ladder trabeculation pattern. This is one where they didn't make a flap. They just anesthetized, took the needle, and it fell right down into the hole. Look at the top of the alveolar ridge here. You can see that is not as hard and as dense as it should be. Here's one where they have a round area around radiolucency with some calcification. Another one similar. This is from West Shanklin, general dentistry. It's also been printed in Cranio as well, the same diagram, where he's showing that you can have lesions in the jawbone, you can have necrotic bone, fibrous marrow, which is one of the findings that we usually see. Some of these lesions, when you open up into them, as I said, are hollow. Some of them have a leathery consistency. Sometimes the bone is real soft and mushy. Sometimes it's fairly hard. But it's all abnormal in consistency. Here's the actual lesion itself. Look what has happened to the nerve. If the lesion is down in the area of the vascular bundle, it can become demyelinated. There's thought that may be why some of these neuralgia problems are existing, and why finger pressure, brushing your teeth, scratching their face, those sort of things can trigger, in some cases, quite extreme pain. There also is a fistula tract that in this diagram is shown to bypass a vital tooth and go to the area in front of it. That may be part of the answer to your question, Steve. I borrowed these from my mentor, Wes Shanklin. This is an area where anesthetic has been placed, a flap opened, and there's the lesion. Another in the upper maxilla. This is a cavitat scan for those of you who haven't seen one. The computer takes the input of the sound waves on the receptor, and if the sound waves come at the speed that they're supposed to pass through the bone and with a certain intensity, you'll get a green. The computer shows it as green. If the sound waves are slowed down, then you get varying shades that go from light green to yellow to browns and to red, red being the slowest. Anyone that's been around a lake knows that you can hear people talking across the lake because the sound waves is being carried by a dense material. Listening to the railroad tracks, the same thing. If the bone is less dense and does not have moisture in it, then the sound waves slow down. And so that is the basis for how this can show these possible areas of pathology. This is the pano of the same area. Notice again that there's a discrepancy on the top of the alveolar ridge and radiolucency below. I went one too far. This is when it was first opened. This is after the roof has been taken off. And notice that it's right in the center of the ridge, which is exactly where the cavitat showed. I have found that this device is very accurate in my office. In the literature, it's described as a disease of blood flow. Dr. Kluck, again, Robert McMahon, Jerry Bacot, Dr. Bick from the ThromboCare lab in Dallas, Texas, Dr. Berg from the HEMEX lab out in Phoenix, Arizona, and others have described this as a hypercoagulability of the blood problem. Boy, I wish this thing would work. It's also described in the literature as a heart attack in the bone. So as you can imagine, if you have a blood flowing through a tiny artery that is thick to start with, and then because of steroids, infection, trauma, you get a thrombus in the blood vessel, then the area that is supplied by that artery is not going to have oxygen and nutrients, and the bone is going to die. That's the basis for this comment. If you do the lab tests from some of those laboratories that I mentioned, and you find that there's a tendency, which can be either because of the state of health of the patient or because of a genetic predisposition, then you can take preventive measures to try to treat that problem before you do treatment. Some people are using homeopathic, some are using like nattokinase, some are using bromelain, some are using heparin. Dr. Berg from HEMEX recommends heparin. Normalize the blood flow before you do any treatment. Then your odds of successfully treating the problem is enhanced. Other factors contributing are trauma, vasoconstricting anesthetics. If patients already have a reduced blood flow and you hit them with some epinephrine and slow the blood flow down more, you're asking for trouble. Radiation therapy, inflammation, infection, failed endotherapy, overheating the bone in surgery, corticosteroids, occlusal trauma. There's more. I think the battery on this thing may be wearing down. Atmospheric pressure changes such as deep sea divers, sickle cell anemia, pregnancy because of hormone changes, homocystinemia, which goes along with the C-reactive proteins, inflammation of vessels, osteoporosis, hyperlipidemia, hormonal therapy, smoking, and alcoholism. All of these can be traced back to alterations in blood flow. As I said, diagnosis is difficult for many reasons. Some of these lesions are not painful. We've already talked about the visibility problems on radiographs. Some are not even inflamed. You don't even see any redness in the tissues. But because there are no outward symptoms does not mean there's lack of pathology. So to help with diagnosis, we're using CAT scans, MRIs with filters, digital radiographs that can be enhanced and made to be negative, Tech99 scans, cavitat scans, as we've mentioned, finger pressure injections, and energy devices like EAVs. Those are instruments developed by Dr. Voll from Germany that uses acupuncture meridian sites and basically an ammeter to measure current running through certain areas. Muscle testing as taught by Dietrich Klinghardt, who also is from Germany and now has a medical practice in the Northwest. Scanners and others like the Whisper and the Biomeridian and other devices like that. After using all the available methods for diagnosis, the question remains, do you treat or not? And if so, what protocol do you use? That's what we're trying to find out. Options are, if it ain't broke, leave it alone. Other options are treating it without surgery. There's many different options available. We'll talk about some of those here in just a moment, and a surgical correction as well. But the issue is, if you leave it alone, Dr. Haley has found in some of his materials that have been sent for analysis that there are toxic materials as yet identified in some of these, which can result or may result in ill health and further tissue, which involves osseous, vascular, neural, and other soft tissue breakdown. So the ethical question is, are we doing all we can do if we decide not to treat? The non-surgical protocols include things like injections with Sanums and other pleomorphic remedies. A lot of those come from Europe, where they're taking devitalized bacteria and virus and other things, and they're injecting those into the site and around the site with the hope being that there is an immune stimulating and a pathogen targeting, kind of like our laser-guided bombs. The body, because we're dealing with non-vascular areas in the bone, sometimes the body can't get our immune cells there to realize that we've got an invader. So the thought is that if you can put something in the area around and stimulate that, sometimes we'll fire up our immune system. Phil Malika and Robert Harris are teaching ozone classes, and at our last meeting they were saying that they're seeing promising results not only for this but also for the bisphosphate-induced osteonecrosis problems. And as we saw earlier in the pictures, if you try a surgical approach, then you want to be thorough with removing the pathologic tissues. After you've gained good access, treat down to the healthy bone, get a good bleeding base, be thorough in trying to make sure that you've gotten every bit of the lesion out. Sterilize and cleanse with sterile water, ozone water, and after you've finished with the sterilization, then you can place bone grafts or any other healing medicaments in that you choose, and then obtain a good primary closure. I like to use some of these supporting therapies, the Sanums and the ozone. Laser and infrared has been shown that it'll dilate blood vessels to keep your blood flow open. It also dilates lymphatics to allow the lymphatics to drain. It also stimulates the natural endorphins for pain control. You want to make sure that the patient has a good nourishing diet so that they've got the building blocks for rebuilding. Because of some of the toxic materials that we're finding, there are those that recommend doing colonics or bowel flushing, because we know that some of these toxic materials can be absorbed into the surrounding blood flow and will wind up in the bowel. If you don't have good bowel function, then some of these things may stay in there long enough to get reabsorbed. So some are recommending colonics. As we heard from our last lecture this morning, vitamin D and other antioxidants are helpful. Hyperbaric oxygen, because this is a blood flow issue, are helpful in treating these particular types of jawbone osteonecrotic lesions. We'll talk about the bisphosphonate-induced lesions that are supposed to be refractory to hyperbaric oxygen because they're formed by a different, they're osteoclastic involved. And also the energy treatments that we had discussed earlier. It's my opinion that we should always biopsy these samples that we're taking out of the bone and any tooth materials as well. We want to make sure that we're ruling out neoplasms and cancers. And it's also good for your records to have reports that come back that tell you what you're dealing with and whether there was toxicity involved. As I mentioned, Boyd Haley has a lab that actually analyzes the teeth and some of the bone samples, and they're finding things that are so toxic that we have no idea what they are. Hydrogen sulfide for years has been the standard for the most toxic substance that the body can manufacture in death of organisms and things of that nature, and they're finding things that are far more toxic than that. So far they haven't been able to isolate and know exactly what they are, but they're extremely toxic. So in conclusion, the jawbone can be afflicted with osteonecrosis the same as all the other bones in the body. Diagnosis is difficult. We have ethical and moral issues and also educational issues. We're not 100% sure which of these techniques works the best. We need to find out. There's a broad array of treatments available, and obviously more research is needed. Now I'm going to talk a couple of cases if I've got time. Let me check my time here. I think we're doing fine. I'm going to mention a few cases that I've treated, and I'll state from the outset that I am certainly not the most experienced practitioner of these types of lesions. I didn't even really want to do them, but there weren't very many people that were doing them in our neck of the woods, and so I felt compelled to see if I could help some. I had a case, a lady that was in her late 40s came to see me several years ago, back around 1999 or so. It was after I had seen the surgery down in Puerto Vallarta, and it was about the time I was going through Capital University and was getting instruction there. And she tells me a story upon questioning of her dental history where she was a victim of spousal abuse and had taken a blow in the maxilla and the zygoma area, left side. She was in pain for a while, so she sought out an oral surgeon who diagnosed a bad tooth, number 16, and proceeded to remove the tooth. After the healing had begun, she realized that she was no better off. She was still in pain. So she tolerated that pain for a while, sought out a different oral surgeon for the second visit, and that oral surgeon diagnosed removing tooth number 14 for her, which was done. And again, same solution. She did not get any pain resolving. And it was after that, a few years, that she came to my office for the first time. And since I had no practical experience in treating these, I referred her to another oral surgeon down the street, whom I know had had some training, although it was extracurriculum at one of the dental schools out on the West Coast. So he was at least knowledgeable about at least the theory that these lesions existed. And he looked at my radiographs and he says, I don't see anything that I think I can do for this lady. So he sent her to a pain clinic where they started her on Tegretol and some of the other big pain meds. And when they ran out of options and couldn't help her, they sent her to a second pain clinic. And they treated her for a while, and then they said, we think this is all in your head and that you just want to be treated with pain medicine. So she came back to my office very depressed and said, this is what they're telling me. And she says, I can assure you this is not the way I want to live my life, but I am in pain. So I said, certainly, if anybody knows about these lesions, it would be the dental school. So I sent her to the local dental school. And I wrote a letter, and I outlined what I could see on the radiograph, and that I had a hunch that it might be a cavitational lesion, and would they review that for her. And the patient called me up and said that she was coming back to see me, and I subsequently got a call from the oral surgeon at the school who says, yes, we believe she had a neuralgia problem, and we recommended treating it with a thermal ablation treatment where they're going to stick a hot needle up one of the foramina and kill the nerve to get rid of the pain. I said, well, what about the lesion that I could see on the x-ray? He says, we don't believe that you can have osteonecrosis in the maxilla because it's so highly vascularized. And I says, well, that's not what I'm reading in the research that I'm familiar with, but thank you very much. So the lady came back to see me, and I took her to the other oral surgeon, and together we worked on her. We got her numb, we opened it up, we probed the bone just like I'd seen down in Puerto Vallarta, and we found a hollow lesion next to the distal root of number 15 that was about the size of a brown bean in size. It was hollow. So we're fumbling around, scraping and curating, finally get to good bleeding bone, and we sutured it up. I called her the next day and asked her how she was doing, and she says, well, I'm still hurting from the surgery, but the pain's different. So I said, I'll talk to you next week when you come back for post-op. A week later, we took the sutures out. She says, I'm feeling better. 2 weeks later, I had lunch with her at the local Luby's, and she said, for the first time in 8 years, I'm pain-free. I wrote my doctoral thesis at Capital University on this one case report. But what would have happened to this gal if we hadn't treated her? Another case. I'm not sure why my letters are, because on the other screen they're not that way. But anyway, that says case history. I had a local school teacher who was a patient of mine. I had seen her for a year or two, and she, on one of her recall visits, came in and says, you know, I'm about fed up with this root canal on this lower molar. I said, well, I wasn't aware you were having problems with it. She says, oh yeah, I had it done many years ago before she was my patient. And she says, it's hurt off and on ever since, and sometimes it's more involved, sometimes it's not. So I don't believe I had my cavitat at the time. So we decided, because based upon her pain symptoms and she did not want to have the root canal retreated, that we would take the tooth out. So I removed the tooth and found soft bone in the furcation of the bone and curetted it out, cleaned it out the way that I knew to do, and got good primary closure. And when she came back for post-op the next week, she says, you won't believe this, but the chronic bladder infection that I've had for 6 years is gone. I said, I knew nothing about the bladder infection. She says, oh yeah, I've been on antibiotics for about once a month for the last 6 years. I said, well, why didn't you tell me about that when you became a patient? She said, well, that doesn't involve my teeth, so I didn't think it was necessary. But this is another case where removing a toxic tooth made a difference in a patient's life. Last case I'll mention to you is a lady that was in her mid-40s that had been treating by one of the local holistic physicians in my area. And she had been told that she had chronic migraine problems, and these would put her in bed once a week or so, and had been for many years. So when we saw her, we noted that she had a stainless steel crown on tooth number 2, and we had the cavitat by that time, and so we did a cavitat scan, and the bone in the area around tooth number 2 and possibly number 1 showed unusual, although quite honestly I couldn't see any difference on the radiograph on this particular case. Took her a while to be able to do the surgery, and she was working with the holistic doc to make sure that she was ready for the surgery. And probably 3 months or so ago, we were able to go in and remove tooth number 2. She did not want a root canal. We took the tooth out, again found soft bone in the furcation area, so I was removing that with my curette, and then I started pushing against the distal wall of the socket and fell into another lesion that was back where number 1 had been. This lady had a mouth that was about as big as a golf ball, so access was extremely difficult, but we did the very best that we possibly could for her. And she was back for her regular prophylactic visit just a week or 2 ago, and said that the headaches are gone. So, I would not ask you to take what I'm saying as gospel. I've had the opportunity to speak to some of the chiropractors over at the chiropractic school, and I was talking to them about alternative dentistry and how it can affect people. And I always told them, I didn't want them to believe what I said. If you have an interest and you believe that there may be something to this, do what I did and start looking it up and do your own research. And hopefully you'll find, as I do, that there's enough basis for making the claims that we made in our position paper. So, in summary, the IAOMT has determined that paper was needed, and we've been working on that since 2006. And we presented it to the Scientific Review Committee in 2008. The paper was based upon peer-reviewed journals and literature. Much of it I've talked with you about already. Textbooks, clinical research, and lectures. We do have the library at the Academy office, and the position paper is now under review by the Academy. Again, we went over historical and current literature and found compelling evidence of the existence of human jawbone osteonecrosis. In the paper, we acknowledge that the issue is controversial. Differential diagnosis is essential due to the nature of the disease and the difficulty in seeing it on conventional radiography. We feel that education of the public and of our profession is necessary to forward research into the diagnosis and treatments of this entity. We also need to try to find out what's the best way to treat these lesions. There's no consensus at this point. We need outcome studies to find out. We're imploring the scientific community to support these efforts. The paper in total is about five pages long, contains 29 articles in the bibliography, and describes the clinical observations of what the lesions look like that I've described at the time of surgery. It differentiates between the osteonecrosis and osteomyelitis and gives references for the difference in the histological differences and the pathology differences that we see. I think one of the more important things that bolsters our position is that one of our colleagues has had an issue with a board in the Northeast, and the issue was for diagnosing and treating these lesions. And there was a hearing, and I think the results of the hearing are important, because at that hearing, the hearing examiner stated these three things: that jawbone osteonecrosis is an accepted pathological entity recognized by a majority of oral pathologists in the USA. I believe they quoted 92%. The treatment of this entity is within the standard of care of that state, at least, Pennsylvania. And the use of the cavitat is useful in the diagnosis of these cases of osseous pathology, jawbone osteonecrosis. Now, our paper, we're working on a standard of care paper. The Academy, when we have ideas like this, we put it in the form of a standard of care, and those are reviewed by the Scientific Review Committee. And we're going to make the paper, as Phil Sukel said at the break this morning, we're going to make the paper in one form reviewable by our members. I ask all of you to take the time to read, look at the research, look at the bibliography, make suggestions. This paper is for all of us. We all need to be unanimous in our approval of what the paper says. And then after that, we're planning on putting this on the National Guidelines Clearinghouse. And this is a quote from their website. The National Guidelines Clearinghouse is a comprehensive database of evidence-based clinical practice guidelines and related documents, and is the initiative of the U.S. Department of Health and Human Services. The information is intended to provide physicians, nurses, and other health providers, health professionals, healthcare providers, health plans, integrative delivery systems, which are the insurance companies, purchasers, and others, an accessible mechanism for obtaining objective, detailed information on clinical practice guidelines and to further their dissemination, implementation, and use. We feel, the IAOMT feels, that this is an excellent way to further our objectives regarding the dissemination of information that we feel is important to the public and to our peers. All knowledge goes through three distinct phases, and these are mine. First, it's rejected. Then it's ridiculed, and then it's finally accepted as fact, and in some cases, others accept the credit. Thanks to all of those that have pioneered the knowledge and suffered the slings and arrows of an unaccepting world.